Hi, I'm Caitlin Parks, and this is our quality improvement project looking at pediatric return visits within 48 hours to our emergency department. Our kind of goal with this was to look at this quality of care indicator and see if there were features within our patient populations that increase the chances of having an unplanned 48-hour return visit to the emergency department. We looked specifically at patients who were presenting with respiratory issues or viral illnesses, and we collected data just over a year. The information that we collected included their vital signs, if vitals were done by nursing or respiratory therapy, if there were differences there, and past medical history, particularly including asthma. The main findings that we found that I think are practice changing really is the SAT less than 96% was associated with statistically significant higher return rates. There were certainly some vital sign discrepancies that we found, and we were glad to see that we were providing fairly equitable care. There were not any flags of statistical significance of difference in people's primary language, demographics, insurance, or zip codes. And then the discrepancies that we found in their vital sign measurements were primarily between triage nurse and respiratory therapy. There were some differences in night shift discharge, and with those discrepancies, nearly half of our patients had pretty significant discrepancies, which kind of draws up the importance, I think, particularly in pediatrics, of truly counting out a longer period of time to measure things like respiratory rate in particular. And so with our findings of this, particularly the non-clinically significant hypoxia, but significant with return risk within 48 hours of pulse ox 95% and lower, our plan was to give education to the physicians and potentially have a more support in place, either in the description of what they were discharging them for, what their return precautions were for, and potentially looking at, developing a handout or protocol kind of thing, like a checklist. This was somewhat limited by some factors with us not actually admitting pediatric patients anymore, and so in our kind of future iteration of the quality improvement, that is limited by not necessarily being able to know if our return visits have decreased because we are telling people if they need more care, they should probably go somewhere they could get admitted, or if it's actually related to our educational initiatives. But we're happy to present this project that we worked on collaboratively to improve our pediatric care. Thank you.